let's talk about malnutrition, one of my favorite subjects. I believe that as nutrition experts, we need to take the lead on this. We need to make sure that we are the ones that identify and treat malnutrition. And of course, this we're gonna do this in collaboration with physicians and other healthcare professionals to make sure that the patient gets the best patient care. But we should be right there in the lead. At the end of this presentation, you will be able to describe the impact of malnutrition, why diagnosing and treating malnutrition is so important. We're also going to talk about what are the evidence-based clinical characteristics of malnutrition. We're going to talk about the nutrition-focused physical exam. That's when you go and like touch patients, and I'm sure that you cover it at school. We also going to talk about what are the different types and the severity of malnutrition. We're going to talk about ICD-10 codes because, of course, we want to make sure that the hospital get reimbursed for our work. So we need to write down the proper terminology for billers to be able to bill this diagnosis and get reimbursed. We also going to talk about possible PA statements related to malnutrition, and this will include the ICD-10 codes. And we're going to talk about the importance of collaborating with other healthcare professionals for the perfect patient care. And of course, when we talk about malnutrition, we're talking about undernutrition. And this can occur because the patient has inadequate energy intake, and this could be something that is long term or as short term as 5 days. Also, increased needs. A patient that is in the hospital might have many conditions, many diseases that speed up the metabolism, so the patient is hypercatabolic. There could be impaired absorption. For example, like someone with cystic fibrosis definitely will have impaired absorption, and it could last occur because there's an alteration in the transport or in the utilization of nutrients. Why do we want to identify and diagnose malnutrition? Well, nutrition is significantly helpful to like in the development or in the outcome of patient care. When a patient is malnourished, there's an increased morbidity and mortality rate. There's a decreased function and quality of life. There's an increased frequency and length of hospital stay. And my old ICU director used to say that the hospital is the worst place a sick patient can be because the immune system is decreased. And with that, it's open season. He or she might be able to catch any diseases that come his or her way. And of course, the hospital is full of sick people. And although hospitals have like a lot of measures in place to decrease the rate of infection, it does happen. So doctors want the patients in and out as fast as they can. Also, there's an increased readmission rate. There has been many interesting studies where even just like giving the patient supplements after discharge will prevent readmission to the hospital. Of course, if a patient stays longer in the hospital and is sicker, that's going to cost more to everyone. The insurance companies, the patients' own expenses. So yeah, that's another consideration. And of course, there's frequent falls and limited mobility. Malnutrition is severely underdiagnosed. I'm sure that it has improved over time, and I will be looking for new numbers. But when this big landmark study came out, or the consensus paper by the Academy of Nutrition and Dietetics and Aspen, well, 15 to 60% of patients admitted to the hospitals were malnourished, but only 7% were diagnosed. I know that in our hospital, we did not use the proper terminology. We identified them, but we didn't call it severe, protein calorie malnutrition. We call it several ways. If it was us, the nutrition team, we usually will call it malnutrition or underweight. Physicians will call it low albumin or failure to thrive. We treat the patients. That was not our issue. Most patients will be treated one way or another, either because we thought they were malnourished or will identify something else. However, many patients fell through the cracks because it could be people that were like on the higher BMI side. So physically, they would look well nourished, but of course, they probably like went down from 260 pounds to 220 really quick. So they were malnourished, but because physically they didn't look malnourished, then we didn't properly assess them and just did not treat them because we didn't know that they were malnourished. Um, and again, all hospitals that I'm aware of, they have implemented malnutrition diagnosis and treatment one way or another, but I think there's a lot more that we can do there. What are the malnutrition effects in the body? Well, it impacts all organ and tissues, from GI function, immune system, wound healing, pulmonary function, cardiac function, and renal function. When we talk about malnutrition and GI, well, when a patient is malnourished, inflammation can happen, and of course that impacts like many diseases, from like cardiac disease to many others. There's also a change in intestinal blood flow, and the big one for me is the functional integrity, because just the GI is formed with like it's formed by very tight junctions. So like it's really tight, the system. It doesn't let bacteria in. But when you have a patient without food, without nutritional support, it becomes more permeable. And with that, like bacteria can pass from the GI through the blood system. And of course, eating something with bacteria is like super easy to do. And there's not a lot of effort to be able to do that. And that's not a big deal because usually our GI can just deal with that. But if we are malnourished, then it's really easy that's going to go, that infection is going to become systematic, and it could be like a really big deal. So, and this happens really quick. That's why we want to initiate nutrition support within 24 to 48 hours of admission to the hospital, if they need, of course. There's also risk for multiple organ dysfunction. Pancreatic enzymes enter lymph, forming toxic gut-derived lymphs, and this could affect many other organs. So that's exactly what you don't want, and that's something that already happens to ICU patients. So the more that we can do to prevent and really provide nutrition is a very, very easy thing to do for most patients. Also, if you remember, your heart is a muscle. So when a person is malnourished, that muscle is going to get weaker and is going to result in a decreased cardiac output. Also can reduce renal perfusion and glomerular filtration rate. So your kidneys are not going to function well, your heart is not going to function well, or I will say the patient's organs are not going to function well. Also, now that COVID has been taking over our lives for like almost a year now, well, with malnutrition, there's an increased factor for pulmonary failure. It's also associated with impairment of respiratory function, of course, because again, our pulmonary system has a lot of muscles. We need muscles to breathe. And if our muscles are weak, then of course, there could easily be an onset of pulmonary failure. There's also these weak muscles that delay weaning of the ventilator, which is just very bad for the patients. We want to avoid ventilators if possible, and if a patient is on a vent support, we want to get them out as soon as possible. And of course, that's a cycle because malnutrition affects pulmonary failure, but then pulmonary failure makes malnutrition worse. malnutrition in surgery. Malnutrition is so important, or in surgery, it can impact the outcomes of the patient so deeply that it was not nutritionists who, or registered dietitians slash nutritionists, that drive this change, but rather surgeons. Surgeons wanted to make sure that in their manual for best practices, they included four best practices related to nutrition. So it's been the surgeons calling dietitian and giving patients nutrition supplements before surgery and trying to ensure um, good nutrition as much as they can prior to surgery. And this movement started with patients that were um, going to get operated for GI issues, because most of them, of course, as expected, they will be malnourished at the time of surgery. And that resulted in 3 times greater risk of having a complications if malnourished at the time of surgery, and they were also more likely to die. At the time of this study, and this again was like with the big landmark study, like only 1 in 5 hospitals had a formal nutrition screening process. And most surgeons believe that peri-op nutrition will delivers or will reduce the complications of surgery, and that's actually really true. And but it's still, like, very few patients really receive pre-op nutrition intervention. When we talk about critically ill patients, and you'll review a video about this, the malnutrition prevalence increases significantly, almost 40 to 80% among ICU patients are malnourished. There's acute skeletal muscle wasting in ICU patients. Is the diagram muscle loss is kind of noticeable. So screening for malnutrition in the ICU is especially important. When I used to do rounds for in the ICU, I will see every single patient. I will not write notes in every single patient other than a quick note saying, yeah, there's nothing to see here. Patient is well nourished. But I will make sure that I review the patient chart in every single one and kind of screen for malnutrition. But beyond that, of course, there's a formal process where nurses will assess the patients for nutrition at the time of admission. And of course, we'll get consults for that, and we'll be able to further assess the patient that a nurse believes needs nutrition intervention. Now, how you diagnose malnutrition? Well, first, do you think that albumin and prealbumin can be used to diagnose malnutrition? And I'm pretty sure you know that the answer is no. Albumin and prealbumin are negative acute phase proteins. They more accurately reflect the acute phase response and reprioritization of hepatic protein synthesis during inflammation. And this is something that you need to learn. Although, like, most physicians are now aware that they cannot use albumin and prealbumin to diagnose malnutrition, you still will see some physicians that will, like, do this, and then they will ask you, and you want to have a smart answer for them. So if we cannot use hard evidence, meaning labs, what are we going to use? We are not going to use BMI either, although there's some evidence now that BMI should be used, but that's not the formal position of the academy. So according to the academy and Aspen, like their main paper about it, well, there's 6 characteristics. 1 is weight loss, 2, insufficient energy intake, 3 is fat loss, 4, muscle loss, 5, fluid accumulation, and 6, diminished functional status. But before we get there, the first step is to determine if inflammation is present. And if it is, then you might have severe or moderate malnutrition. If there's inflammation present and severe malnutrition, Then you might have a malnutrition that is related to acute disease or injury, and usually it's going to be a short time period. If it's mild, it could be more of a chronic disease, and it's something that had last for more than 3 months. Although you can have malnutrition that started with a chronic disease, but then something happened and it just became severe because it was like a further deterioration of the patient. If not, then the malnutrition could be related to starvation, for example, like an anorexia or environmental factors. And this is like on an extended period of time. Acute disease or injury related malnutrition. Usually, this is severe or moderate, and this might be related to a major infection, sepsis, burns, or trauma. Like someone gets into a car accident and suddenly is like no food because something is going on with the GI. That could be the cause of the malnutrition. It could be because of major surgery involving any major organs, and pretty much everything that ends up with itis, which is like the inflammation, swelling, erythema, hyperthermia, pain, mark elevated C reactive protein, and that's a lab that you might find sometimes. And I used to order it a little bit more, but like really now I don't too often. And the body is producing inflammation because it needs to defend itself to clear up infections or anything that is going on, or is getting adapted to a new condition, and of course the body needs to repair itself. When the malnutrition is related to chronic disease, usually you will see diagnoses such as cancer, any form of heart disease, cystic fibrosis, celiac disease, of course, like any GI diseases, diabetes could be, and then of obesity and rheumatoid arthritis. And of course, I mean, this is not like a list that includes all diseases, but anything that that has been going on for a long time. And the main reason of inflammation is that you want to restore homeostasis of the body. Now, malnutrition that is related to social and environment, it's this is anything that limits the access to food, or when the patient is just not gonna eat. Again, as for example, what happens with someone that has anorexia nervosa. There's no inflammation, and some of the diagnosis, or not the diagnosis, but some of the things that you will find in the chart is that there's economic hardship, maybe there's a cognitive or emotional impairment, there's an inability or desire to manage self-care, and this happens a lot to older adults. For example, like one spouse died, and then now you have like a very old lady or gentleman living alone at home, and they really can no longer cook, or they just don't feel like cooking because they're alone and they just don't have the motivation. And it could be also due to poor oral dental hygiene. Now, when the patient is in the hospital, how we diagnose malnutrition? Well, this is when we roll up our sleeves, put on gloves, and go and see the patient. But before we see the patient, we want to evaluate the chart, and we need to be ready for some questions. We need to find out if the patient has lost weight, and in what time period, because the diagnosis of malnutrition is tied up to a specific percentage and a specific period of time. So, for example, someone with the acute illness or injury, the weight loss could be in a week, in a month, or in 3 months, and there's a different percentage for all of them. Or it could be due to, or if it's moderate, for example, you also gonna see that it's a week, 1 month, and 3 months, but the percentage of weight loss will vary. So that's one, weight loss. Second is energy intake, and this could happen really quick. So for an acute one, the energy intake of less or equal to 50% of energy intake compared to estimated energy intake in more or equal to 5 days. So this could just happen super quick, and this is something that might change the diagnosis of malnutrition from like day one when you see the patient to day seven when you see like the patient um, for the second or third time. So, what are your goals for the NFPE interview? Well, the information that you want to get is if there's any weight changes, because as I mentioned before, the patient could be heavy, but if that patient is still lost 2%, 5% in a week, 2 weeks, a month, that also like will reflect malnutrition or one characteristic of malnutrition. You also want to discuss the functional status because that's another characteristic of malnutrition. And then you want to educate along the way to ease the patient into it. So because you're gonna now be invasive with the patient, you're gonna uncover the patient, you're gonna move him, her around. So you want to just let them know what you're doing to make the experience a little bit better for the patient. NFE patient center interviewing, there's four or five stages. One is to set up the stage. So you go to the room, you welcome the patient, you like chit chat a little bit about the whatever, just to kind of gain rapport. Then you want to make sure that you understand what is the main reason the patient is in the hospital and if they have any complaints in terms of like food, nutrition, or any concerns. Because once their questions are answered, then they're able to listen to you. Then you want to make sure that you do like open-ended questions so you learn more about the patient, because if you only do yes or no answers, you might really not get to what's going on with the patient. And then you want to focus interview specific questions related to open-ended questions. And of course, the last stage is to transition to provider-centered process, and you're gonna do your NFPE, you're gonna gather information, and you're gonna summarize. So, what if the patient cannot speak? Well, then you ask the CNA, the nurse assistant, and she or he are going to be the ones in charge of actually feeding the patient. So if you ask the nurse might not know if the patient is eating or not, just because they're not the one feeding the patient. If you cannot get information and you need information about the last week, the last month, you can call the ALF, the nursing home where they were residing, and talk to them, or the family members, of course. And that information is always available at the patient chart. And you are within your right to call them. You just have to clearly identify yourself. You're going to say that, you are who you are. You are a dietetic intern at the hospital. You're also going to explain why you are doing this exam for their patient and what are your goals, so they feel at ease and they can give you the information. And you can also find information in the medical chart as well. The next one is the physical assessment. So this is where you assess to see if there's any fat loss, if there's any muscle loss, and if there's any fluid present in the body. And there's a book, let me see if I have it in this next slide, but it's a little booklet by the Academy that helps you to like identify specifically how to position the body and what to look for when you're doing these assessments. Oh, and here it is. Yes, I knew that I had it. It's called Nutrition Focused Physical Exam Pocket Guide. It's really inexpensive and really helpful. So, I encourage all of you to purchase a copy because it's going to save you a lot of time and it's going to help you to provide better patient care. So, what we're looking for? We're going to look for subcutaneous fat loss. And we are going to examine the region around the eyes, the region about the cheek and the mouth. We're gonna also look into like the upper arm, the triceps, and we're gonna look at the back. So as I said before, it's kind of invasive. um, and someone that is well nourished is gonna have like a little fat around it. And granted, as we age, we're not gonna lose some of that fat padding. So you're gonna see that older adults have like a little sunken eyes, but typically you can tell when it's like just age or it's just malnutrition as well. So with in a well nourished, you're gonna see that fat pad. In a mild moderate malnutrition or fat loss, you're gonna see slightly dark circles and somewhat hollow look. And with severe one, you're gonna see like really the hollow look. It's gonna be a depression on the eye, and you're gonna see dark circles or loose skin around the eye. And then with subcutaneous fat loss, you want to make sure that you position the patient correctly. They're extending their arms, they're bending their arms. I mean, as much as you can, because yeah, some patients might not be in the condition to do that, but you try to as your best to have the proper positioning. And as your arm is bent, you're gonna roll the skin between your fingers, and you don't want to include muscle in pinch. You just want to feel like kind of like the fat there. If a patient is well nourished, you're gonna feel ample fat. Of course, if you have someone that is like really fit, you might not see a lot of fat, but you will see like the muscle, and you can imagine it's not a lot of fat loss. Well, no, in a mild to moderate fat loss, you're gonna have some deep pinch, but not ample. And with severe fat loss, you're pretty much gonna feel like skin. It's like folding a paper within your fingers. When you see the back, well, in a well nourished, you're gonna see a full chest. You're not gonna see any ribs, and there's just gonna be no protrusion of IC. And when you have mild moderate, you're gonna see more of the ribs. It might not be like the full on ribs, but you might see some ribs, and you're gonna see some depression between ribs. And with fat loss, you're gonna see the ribs very visible. Like severe fat loss, you really see it. When if you want something like more like accurate, using a caliper is the best. We don't really have calipers at the hospital because of the risk of infections right now, but we will have in the future, and I think that gives you like a more adequate like measurement. Then because this is reimbursable, I want to be as accurate as possible. With the muscle loss, the places that we're going to look at is the temporalis, the clavicle region, the acromion region, the scapula, the dorsal hand, patellar region, anterior thigh, and posterior calf. And with the dorsal hand, you could see that as soon as you walk into the room, you extend your hand to greet the patient, and as you shake the hands, you can feel the muscle most right in between fingers. Of course, I will encourage you right now to wear gloves, and at any other given time to wear gloves, as part of universal precautions. In muscle wasting, you not all the time have the same muscle wasting in both arms, and if you see that one arm uh, is wasted but the other one is well nourished, it might not be related to malnutrition, but it might be related to something else. For example, the patient have a stroke and lost function on one side of the body. For the temporalis, this is the criteria. So again, you're gonna see that hollow look in someone that has severe muscle loss. In the clavicle and the acromion process, of course, like women, we tend to have more clavicle, like a little bit more pronounced, while men have less of that. But you could see the bones stick it out in someone that is malnourished, and like when you touch them, you're gonna feel like there's just no muscle mass. Now, keep in mind, there's some people whose like body just kind of like shows clavicle. And that's something that you learn as you see more and more patients. The scapula, for someone that is well nourished, bones are not prominent, there's no significant depressions, these become a little mild. And then for severe muscle loss, there's predominant bones. And I'm sorry, my dog is making noises, so if you hear anything, that's my dog sneezing and yeah, sleeping. Actually, he makes a lot of noise when he sleeps. Let's talk about the dorsal hand. So if you ask them to do an okay sign, you're gonna see that in a well-nourished patient is it bulges or like flat, but you don't see a depression there. For a mild, moderate muscle loss, you're gonna see a slight depression, and with severe loss, you're gonna see a depression area between the thumb and the forefinger. Then in the patellar region, this is the positions you want to see. You want the leg bent so you can truly assess the patient. And again, you're seeing like you're finding the muscle there. In the calf muscle, well, you could see like with someone that has muscle, it's gonna be that like well developed bulb of muscle, but with somebody with muscle loss is going to be a bit thin, is going to have minimal or no definition. And one thing you want to be doing is as you assess your patient, you have to be filling out this chart that we're going to provide you about the severity of malnutrition. Um, And again, during normal times, that's something that I just used to have in my pocket and just fill it out in as I went along. I know that with COVID, there's a little bit more precautions that we have right now, but you need to be like noting all of these because you're going to need it to write your note. Functional assessment is the next step, and for that, we do have something similar to what you see in the picture, except that is digital and plastic, but it has the same function. It measures the strength of the hand. Um, I'm not sure we're using it a lot right now with COVID, but that's like a bit, again, a bit more of accurate assessment. But you can just assess the functional like assessment in many other ways. For example, you can read the notes of the PT, or read the medical notes, and in there many times they're gonna give you like really strong evidence about the functional strength of the patient. Um, this is just fun to do. So at some point, just go to this video and see how many times you can sit and stand up, and that's another measurement of how well the body is functioning. Now the last step is fluid accumulation, and pretty much you're just gonna touch the body and you're gonna see how much the skin sinks. If it's less than 2 millimeters, is 1 plus edema, 2 to 4 is 2 plus edema, and 4 to 6, 3 plus edema, and 6 to 8, 4 plus edema. And again, that together with everything else is going to determine the malnutrition. I will send you a link about how this is done, because I think like seeing it's a lot more helpful than just me talking about it. So I'll give you a link to the video. And that's it. That's the NFP. Now you're gonna take this information, and if you have, if the patient meets criteria in 2 places, so meaning, for example, you find that patient meets criteria in muscle loss, energy intake. That's two criteria met. And in those categories, you found out the malnutrition is severe, then you're going to classify that malnutrition as severe. If you see the 2 criteria met in moderate or the severe column, but is more in moderate, then you're going to have moderate malnutrition. and there's no criteria for mild at this time. The academy decided like not to use it anymore because it was a very hard distinction between moderate and mild. So yes, again, seeing it is easier than me talking about. So as you do your assessment, this is what you're gonna do. You're gonna select the columns, and in this case, you see there's two in moderate and only one in severe. So this patient will have moderate malnutrition. Now, how you write down this diagnosis, you have to use ICD-10 codes, because if you don't use ICD-10 codes, then chances are that it's not gonna get reimbursed. And of course, dietitians, we cannot medically diagnose any disease. However, what often happen is that the physicians will see our notes and they will just mimic what we did, because at the end of the day, we are the ones making the diagnosis. And once the physicians write down a formal diagnosis, if they agree, of course, that's going to become something that the billers can use to get reimbursements for malnutrition. So it's really, really important that you do it the right way. Malnutrition can get reimbursed up to like $15,000 per patient. Is really a major comorbidity. So it's a big deal that you do this right. So right now there's two ICD-10 codes. One is unspecified severe protein calorie malnutrition, and another one is unspecified protein calorie malnutrition. So and those two will make a big difference in the reimbursement. So if the malnutrition is severe, you want to write down severe. And that's pretty much what I use in my PA statement. For example, I will use unspecified protein calorie malnutrition. Now, my related to is whatever is causing malnutrition. In this case, it was like a chronic illness, and this could be right like a slightly different, like like related to portion and the as evidence based portion. Those two doesn't have to be set in stone. It has to be like something that truly reflects what's going on with the patient. But usually I like to write down what is the context in which the patient has malnutrition. And then the evidence by I like to write down my characteristics that I found. So what is the supporting evidence of the malnutrition? So for example, in this case, the intake was less than 75% of energy needs. And that's right according to my chart. That's exactly how they write it for 1 month. And there's also a 5% weight loss over 1 month and moderate muscle wasting. So I give like strong evidence of my malnutrition diagnosis. And we are going to have the chance to practice in the next section with Natalie. Have a great day.